Welcome, everyone. Thank you for joining us for today's webinar, Lung Cancer Screening, Breaking Barriers to Preventative Care. Please note that this event will be recorded. My name is Dr. Jeroen Nijwenning, and I'm a board officer for the Florida Lung Health Coalition, which is the main sponsor of this session. Our goal at the nonprofit Florida Lung Health Coalition is to accelerate the uptake of lung health screening. Our aim is to screen 30% of Florida's eligible population by 2030. Currently, we are looking for industry partners, volunteers, and donations. I'm joined today by three presenters, and we are fortunate to have them share with us their extensive knowledge of lung disease and population health. First is the Honorable Dr. David Shulkin, the 9th Secretary of the U.S. Department of Veteran Affairs in the Trump administration and VA's Undersecretary of Health in the Obama administration. Our second speaker is Dr. Scott Brandman, a radiologist and specialist in thoracic imaging at Arizona Diagnostic Radiology. Concluding with Dr. Matthew Nynan, a general thoracic surgeon and director of thoracic surgery at HCA Florida Healthcare West. Welcome, gentlemen. Just a brief word about our agenda today. Each of our presenters will provide their insights on the importance of lung screening for about 10 to 15 minutes. We will then conclude by taking questions from you, our attendees. For the Q&A portion of this meeting, we will be utilizing the Q&A section of Zoom. Please feel free to type your questions in Q&A at any point of the presentation. We will answer as many as time allows at the end of the session. That takes care of the logistics. We begin with Dr. Shulkin. Dr. David Shulkin is a board-certified internist and served as chief executive in prominent hospitals. He was the 9th Secretary of the U.S. Department of Veteran Affairs, representing 21 million American veterans. He was responsible for the nation's largest integrated healthcare system, with over 1,200 sites of care. Thank you for joining us, sir. Please go ahead, Dr. Shulkin.
Great. Thank you. And I appreciate everybody who's joining the call today. I know some of you have experience in working in VAs. Many people have trained in Veterans Affairs hospitals. Approximately 70% of all American physicians have done part of their training in VA hospitals. So many of you will understand some of the things very intuitively that I'm going to be talking about today. But for those of you who are in the community, I'm sure that you have many veterans in your practice. And just to give you a sense about the way that the current VA works is there are two systems, the VA care that's delivered within VA medical centers and then VA care that's delivered in the community, which means these patients come see you and VA pays the bill. That's approximately 42% of all care now in the country is provided by community-based physicians. So the first slide that I have is a picture that many people will recognize. This is the World War II pictures, the pictures of the old GIs. And in fact, the government would give 12 cigarettes a day to each GI as part of their general ration. So you would get your food and 12 cigarettes. And those veterans that didn't smoke would trade them for other things. But it was very typical to see a veteran, particularly those who were exposed to a lot of stress, with a cigarette in their mouth. And because of that, veterans are more likely to have lung cancer than the general population, about 25% more. And again, that's important for you to understand as you're caring for these people in the community. But also, in addition to having a higher risk, the survival rate has historically been lower. And that probably is because of later diagnosis and more severe types of cancers that present. So this is a issue that's of deep concern to us who care for veterans. On the next slide, I wanted to just talk about the way that VA has handled medical and lung screening, particularly given this higher incidence of smoking, this higher incidence of lung cancer, this worse outcomes that are seen in the veteran community. And so VA has long had the recommendation of the United States Public Health Service of doing annual screening for veterans 55 to 80 with a 20-year PAC history. And so this is consistent. It's what VA will pay for in the community, and so very similar to what you're seeing with your other patients. Now, next slide, please. Um, when the next slide, please. When the pandemic hit, I think many people felt that it was not possible to do as much in-person screening, that it was more difficult to counsel people. And so the VA, like many others, went very, very quickly to telehealth. When I was secretary, I'm a general internist. I always saw veterans, and I saw veterans in person in New York City, but from my office in Washington, I would see them using telehealth. This is actually a slide where I brought my telehealth equipment to the Oval Office at the White House. I asked the president for special regulatory authority to be able to allow all VA providers to be able to use telehealth uh, to cross state lines, in other words, to use federal supremacy so that we could reach as many veterans as possible. And as you probably know, about 45% of veterans live in very rural areas in the country. So getting access to uh, providers to talk about screening, to arrange for screening is challenging, but telehealth was a very useful tool for us. And actually, CMS or Medicare followed our regulatory relief in the pandemic from the way that we laid this out with the president for veterans. Next slide, please. So there are approximately 1.5 million veterans that meet the criteria for lung screening. That's a lot of people to try to get through the VA system. VA, as we'll talk about a little bit, is challenged in getting all those through, which is why you'll see a lot of veterans in the community that are going to be in need of lung cancer screening. Next slide, please. Now, how does the VA do in terms of performing lung cancer screening? Well, not actually all that well. When you're a federal agency, you have federal watchdogs that look at how you're performing. And the Office of the Inspector General of the Department of Veteran Affairs came and reviewed how the VA was performing in terms of lung cancer screening. And what it found was, of those veterans that they were screening, that the follow through in terms of getting the results back to the ordering physician, getting the follow up that was needed, particularly when results were abnormal. And about 13% of all 13% of facilities had abnormal results in their lung cancer screening. But what the inspector general found was that about 21% of patients that had an abnormal test, that their doctors weren't notified of it, and that there were not follow-up of those results within 14 days, which is the standard of VA. So VA has struggled in terms of being able to not only perform these exams, but get the results back so that follow-up can be done in a timely fashion. These types of reports help the VA put in more stringent programs, get better. But I think it's important to recognize that when veterans are seen in the community, that making sure that these results do reach a provider, if it's back at the VA or if you as the physician are going to be the follow-up provider, that it's very important that those abnormal results get followed up. Next slide, please. Now, in 2022, something pretty significant happened for veterans across the country, and that was that Congress finally took up the issue of burn pits. And if you don't know about burn pits, it's because burn pits are not legal in the United States. But as you know, many of our military serve outside the United States where there are not as strong environmental laws. And particularly in war zones like Iraq and Afghanistan during this last conflict, 21 years of conflict, what the US military would do is they would just simply set up a dump right beside a base where our soldiers were, and they would burn all the trash. Sometimes that was jet fuel, sometimes it was environmentally hazardous materials that were in waste. Sometimes it was sewage, whatever needed to be gotten rid of, they would burn right next to the bases, and that smoke would all day long be on the bases, and our men and women in uniform would breathe uh, the burn pit exposure smoke day and night. And as you would imagine, a lot of difficulties resulted from that, and especially respiratory issues. Now, while we went into Afghanistan and Iraq, as all of you will remember, after September 11th in 2001, I talked about this issue not being addressed by Congress until 2022. So for 20 years, the VA and our government really did nothing about burn pit exposures. And so veterans would continue to come back with all sorts of complaints, respiratory complaints, cancers, and others, and would have to fight their government for proper evaluations, health care, and benefits. Many of them, of course, lost that fight and died during this time. But in 2022, a number of us really stood up and said, well, if the VA wasn't going to do this, Congress needed to give our veterans these rights. And that's where some of you may remember, not necessarily me, off to the right, you can see that's me and Senator Gillibrand of New York talking about why we needed to get our veterans regulatory help for burn pits. But finally, John Stewart, off to the left here, took on this cause. He had taken on the cause for 9/11 first responders, and then saw the similarities with our veterans and took on this cause. And when John Stewart got involved, the national attention focused on it, and then Congress focused on it. And in 2022, Congress passed a law giving our veterans added benefits for anybody exposed to burn pits. Next slide, please. The president signed the burn pit exposure law in 2022. He believes that his son, Bo, who served in Iraq and Afghanistan, actually died of burn pit exposure with a brain glioblastoma. And so he was very supportive of the Burn Pit Exposure Act. Now, what that said, next slide, what the Burn Pit Exposure Act said and what it means is that while the issue of all of these very toxic respiratory exposures has been studied for decades, the VA had not been willing to grant benefits or health care for these exposures until there was absolutely proof with scientific data suggesting that there was an exposure between breathing in all these things for years and the cancers and the respiratory diseases that veterans developed. What the law said was that we're going to give the veteran the benefit of the doubt. If they have developed these terrible respiratory diseases, these cancers, they can show that they were in areas where burn pits were. We're going to presume that these conditions are related, and we're going to grant them benefits and health care. And so that's called a presumptive. Next slide and last slide. So effective in April of 2022, veterans now have what are called presumptive conditions, where they are given the benefit that if they were exposed to burn pits, that 9 additional cancers and up to 20 other conditions, respiratory conditions, from asthma and sinusitis on the mild side of respiratory to severe respiratory conditions like chronic obliterans, are associated with burn pits, and therefore veteran healthcare is covered, veteran benefits are covered. And so you will now see veterans coming to you with what we talked about in the beginning, that additional exposure to cigarette smoking, giving them a higher risk for lung cancer, 25% higher, many more of them than the general population. Now add on top of that the burn pit exposure, which over 3.5 million veterans have returned from combat zone areas overseas with burn pit exposure. So you will see a lot of those as well, with connections to these respiratory conditions. Both of these, lung cancer and burn pit respiratory exposure, called post-deployment respiratory syndrome, are good reasons to do screening, lung cancer screening, low dose CT scan screening, and other respiratory evaluations on veterans. And with that, I think I'll stop because I really just wanted to make the point that you'll be seeing veterans in your practice. They are at higher risk for respiratory conditions from both traditional exposures as well as these burn pits. These are recognized associations now, and it's very important that we get our veterans the right type of screening and then follow-up results back with VA doctors who know about abnormal results or with other doctors in the community who can follow up on those results. So I think I'll stop there.
Thank you, Dr. Shulkin. Next is Dr. Scott Brandman. Dr. Scott Brandman is a specialist in thoracic imaging. Dr. Brandman interprets chest radiographs, CT, and MRI examinations performed for pulmonary and cardiovascular diseases at Arizona Diagnostic Radiology. Please go ahead, Dr. Brandman.
Thank you for having me. In this session, we're going to take a look at the role of radiology in lung cancer screening and how you can partner with radiologists in your community to have a positive impact on patient outcomes. About 250,000 people in the US are diagnosed with lung cancer every year. In 2023, about 127,000 people died of lung cancer, making it the leading cause of cancer death. And that's nearly 3 times the number of deaths due to colorectal cancer, which is the second most common cause of cancer death. Next slide, please. So why is lung cancer so deadly? We have many excellent treatment options today, and they're extremely effective when the disease is found in an early stage. But unfortunately, almost half of them are not caught until a late stage when there's regional or distant spread of cancer. So sadly, more than half of people with lung cancer will die within 1 year of being diagnosed. By the time symptoms appear, it's often too late, as you can tell in these low 5-year survival rates for those with regional or distant disease. Next slide, please. And that's why screening for lung cancer is so important. For patients who participate in a lung cancer screening program, 70% of the detected lung cancers are early stage, when treatments are most effective. And that is so critically important because we recently learned that lung cancer patients diagnosed in an early stage have an overall 20-year survival rate of 80%. Next slide. And although the smoking prevalence has been showing a downward trend in the US, we still have 28% of adults currently smoking. So tobacco-related diseases such as lung cancer are expected to remain important health problems for decades to come. So how do you identify this 28% of your patient population, and which of them should be encouraged to enter a lung cancer screening program? Well, the US Preventative Services Task Force recommends screening for patients who are 50 to 80 years old, are currently smoking, or have smoked at some point in the last 15 years, and have at least a 20-pack year smoking history. And you calculate the pack years using the number of packs smoked per day when the patient was at their peak of being a full-time smoker. Next slide. Veterans are an important population likely to benefit substantially from lung cancer screening. Veterans have a higher smoking prevalence than non-veterans, and they have unique occupational exposures that may further increase their cancer risk. But the use of lung cancer screening among veterans today is skewed toward those in poorer health. And this could decrease the benefit of early lung cancer detection by exposing them to unnecessary harm because they're not healthy enough to undergo curative treatments. So it's important to highlight the need to promote lung cancer screening among healthier veterans who will benefit the most. There are also significant disparities between white and non-white veterans' rate of participation in screening. This is so important for us to address because the non-white veterans who are less likely to be screened are the ones who have the greatest screening mortality benefit. So this really emphasizes the need to reach healthier veterans, especially non-white veterans who are appropriate candidates for screening. Next slide, please. There are no current guidelines recommending lung cancer screening in firefighters who may develop lung cancer from their occupational exposures. But we know that occupational exposures account for about 30% of lung cancer cases. Researchers have found that even at fires with low smoke intensity, firefighters are exposed to significant levels of toxic materials, including carbon monoxide, benzene, aldehydes, and hydrogen cyanide. And studies have shown that firefighters have higher rates than the general population for many cancer types. Unfortunately, the longer they're on the job, the greater their risk. So I've been interpreting low-dose chest CTs on asymptomatic firefighters and working with Dr. Varshali Shukla at the Vincere Cancer Center in Scottsdale, Arizona, to learn the value of lung cancer screening in this population. And we're now working to increase the scale of the study and to start interpreting the second round of annual follow-up exams. And we look forward to the results, and we hope to impact current guidelines for screening in the future. Next slide, please. Although it's well known that smoking tobacco can lead to the development of lung cancer, many people ask if vaping can cause lung cancer. Since vaping and the use of e-cigarettes are a relatively new phenomenon, the simple answer is that no one yet knows what the long-term effects may be. So researchers are still working to determine if vaping increases a person's risk of developing lung cancer. And it may be some time before we get the answer, because if we extrapolate from tobacco smoke data, it could take 20 years for a cancer to develop. With that being said, many of these products contain dangerous chemicals that have previously been associated with a higher risk of lung cancer, including formaldehyde. So there's clear reason for concern here based on just basic and molecular science. But for the time being, this is not included in the current guidelines for lung cancer screening, yet it may have significant future implications for public health. Similarly, patients with a family history of lung cancer are not yet included in the USPSTF recommendations for screening, yet research has shown that these patients are at 2 to 5 times increased risk for lung cancer, even if they are non-smokers. So we are certain to see recommendations continue to evolve as we move into the future. Next slide, please. Now, once you have identified a currently eligible patient, you can share good news with them because screening for lung cancer is a covered insurance benefit with no out-of-pocket expenses. Medicare covers lung cancer screening for those 50 to 77 years old, and commercial insurance and Medicaid expansion plans cover it for those 50 to 80 years old. But if a patient's health plan was in place before the Affordable Care Act was passed, then it may not offer the same coverage, so it's important for patients to check their plan documents. Next slide. And there's compensation available for you as the provider for taking the time to identify these patients. For example, CMS pays about $29 for completing eligibility determination for lung cancer screening and shared decision-making. Next slide. And CMS recognizes the importance of smoking cessation counseling that you can offer separately to your patients. It reimburses about $18 for an intermediate level of counseling and about $30 for intensive counseling. Next slide, please. So for patients who may express concern to you about having the test done, you can offer them reassurance on several fronts. First, there are no needles or injections, so that means there's no contrast administered, and therefore there's no need for recent blood work. Second, there's no feeling of claustrophobia because CT machines don't have a long tunnel. And the required breath hold for most machines today is only up to about 10 seconds. Also, there's no fasting needed prior to the exam. Next slide, please. It's also useful to reassure patients who express concern regarding radiation exposure. Lung cancer screening uses a low-dose CT scan. So running this exam on a piece of modern equipment will result in a radiation dose to the patient of 0.7 to 1 millisievert, depending on the patient's weight. So rather than going into the physics of what that means, it's useful to put it into context. Depending on the elevation of your hometown, you receive anywhere from 3 to 5 millisieverts in annual natural background radiation each year. If you fly on a commercial airliner, you're exposed to more radiation than when you're on land, and the amount of radiation received during a low-dose CT is similar to 5 round-trip flights between Los Angeles and London. So researchers have looked at the data and found that over the course of a patient's participation in a screening program, there's a lifetime radiation-induced risk of 0.05% for men and 0.09% for women. That corresponds to 1 radiation-induced cancer per 2,500 patients screened. So in terms of a population screening program, this risk is seen as extremely low. Next slide, please. With all of that reassurance, I hope that everyone listening can help identify candidates for screening, because last year, Florida, for example, only screened 2.4% of its high-risk patients. I know that we have some people joining us today from my neck of the woods in Arizona, where 1.3% of high-risk patients were screened last year. And for those of you in Texas, it was 1.2%. And unfortunately, for those of you in California, we saw the worst uptake in the nation with only 0.7% of eligible patients screened. The national rate is also low at 4.5%. But I hope you can take this information back to your practices and make a positive impact on the community by identifying and referring eligible patients for screening. Next slide, please. For those of you who have referred patients for lung cancer screening, you're aware that the result you receive follows a standardized reporting system. When the idea of lung cancer screening was being developed, there was concern about overtesting, radiation exposure, anxiety, the use of invasive procedures, and cost. So we needed a system to standardize our reporting and management of screening results, and a way to facilitate tracking of patient data. From this need, the standardized reporting system called LungRads was developed by the American College of Radiology. Next slide, please. LungRads has evolved over time, and the newest revision was released at the end of 2022. Each lung cancer screening exam is assigned a single category that is based on the most suspicious finding. The system takes into consideration the size of a nodule, change in size over time, and its composition to determine the assigned category. And with that assigned category, a management recommendation will be made by the radiologist to help guide your work with the patient. For categories 1 and 2, negative and benign, there will be a recommendation for the patient to return in 12 months for a repeat annual screening low-dose CT. For category 3, probably benign, there will be a recommendation for the patient to return in 6 months for a diagnostic low-dose CT. For category 4A, suspicious, the radiologist will recommend either a follow-up diagnostic low-dose CT in 3 months or a PET CT in some situations. And for categories 4B and 4X, the radiologist will recommend either a PET CT, tissue sampling, or referral for consultation with pulmonology. Next slide, please. Now, a question that often comes up is, how do you order these things? So a patient who presents for their initial baseline screening CT exam needs an order for an annual screening exam. That is a CT chest low dose for lung cancer screening without contrast that has code CPT 71271. A patient who previously had their baseline screening CT and received a recommendation to return in 12 months for annual follow-up, that patient also needs an order for an annual screening exam. So again, a CT chest low dose for lung cancer screening without contrast, CPT 71271. Now, any patient who previously had a screening exam and received a recommendation for a short-term follow-up CT at 1 month, 3 months, or 6 months, those patients need an order for a diagnostic low-dose CT, that is a chest CT without contrast using low-dose technique, CPT 71250. Next slide. So here is an example of a patient with a non-solid nodule that was just over 30 millimeter on the baseline exam. It's scored as a lung RADS 3, probably benign, with a recommendation to follow up in 6 months with a diagnostic low-dose CT. The reason for the follow-up is to see if the nodule disappears, which would mean that it was infectious or inflammatory. But here on the right, for the 6-month follow-up, the nodule persists and is stable in appearance. So this is probably adenocarcinoma in situ without invasion that isn't going to harm the patient at this time, but needs to be monitored for the development of invasion, which would show up on the CT as a solid component to the nodule. So this nodule is now downgraded to a category 2 benign on the 6-month follow-up exam, and the patient can then return to annual screening with a screening low-dose CT in 12 months. Next slide, please. Here's another case. It has a solid nodule found on a baseline screening exam. It's 13 millimeters in mean diameter, and based on that size, it's classified as lung RADS 4A, suspicious. So the management options are to do a 3-month follow-up diagnostic low-dose CT or to evaluate with PET-CT. The provider for this patient ordered a PET-CT, and it did not show significant radiotracer uptake. Then a follow-up low-dose diagnostic CT in 3 months showed the nodule to be stable in size. So it's now downgraded to lung RADS category 3, probably benign, with a recommendation to repeat a low-dose diagnostic CT in 6 months. Next slide, please. Here is a case where a patient underwent baseline screening and there were no nodules. The exam was scored as a lung RADS category 1 negative. The patient was reminded to return 12 months later for another annual screening low-dose CT, and a 12 millimeter solid nodule developed. The fact that it's a new nodule and based on its size, it is classified as lung RADS 4B, very suspicious. The management options here are PET-CT or tissue sampling. The provider for this patient chose to refer them to an interventional pulmonologist who performed a biopsy by robotic-assisted navigational bronchoscopy, and it turned out to be a small cell lung cancer. Next slide, please. Now, here's an example that I would like to share with you because it illustrates the value of encouraging patients to comply with the radiologist's follow-up recommendations. Here, there's a non-solid nodule on baseline screening that was just over 30 millimeter. It's assigned to lung RADS category 3, probably benign, and the follow-up recommendation is a low-dose diagnostic CT in 6 months. On the 6-month follow-up exam, the nodule is essentially stable, so it's downgraded to a lung RADS category 2 benign, and the recommendation is to resume annual screening with low-dose CT. The patient then comes back 12 months later, and the nodule has become part solid. It now has a new solid component and is therefore reassigned to lung RADS category 4B, very suspicious. And now the management recommendation depends on the clinical picture and the patient's preference. We can evaluate this nodule with PET-CT, or we can do tissue sampling, or we can refer for a pulmonology consult. This turned out to be a case of invasive adenocarcinoma in situ that had a curative resection. And if the patient was lost to follow-up along this timeline, then we probably would not have found this until it progressed to a later stage. Next slide. So I would really like to emphasize the importance of performing the recommended follow-up exams. In fact, the mortality benefit that is associated with lung cancer screening requires a high adherence to follow-up. In the National Lung Cancer Screening Trial, where much of our landmark knowledge and experience with screening comes from, nearly 60% of lung cancers in the intervention group were detected during the second and third rounds of screening. So it's important to remember that helping patients adhere to follow-up recommendations will allow you to identify lung cancer at an earlier stage and improve outcomes. A meta-analysis found a pretty low adherence rate in clinical practice of only 55%, but thankfully all of you now have this valuable knowledge and will work to have an adherence rate in your practice that is much higher. Next slide. Often there will be incidental findings on exams done for lung cancer screening. The prevalence varies between university and community-based radiology practices, and gender also plays a role, but a university-based screening program will find an incidental finding in about 60% of patients. The most common finding is coronary artery calcification. It's very important for radiologists to report the severity of coronary artery calcification because it corresponds strongly with cardiac risk, and the information will often impact treatment strategies. This has been shown to improve cost efficacy and health outcomes. For some of the incidental findings, though, the clinical benefit of reporting them is uncertain. To help mitigate the unnecessary investigation of clinically unimportant incidental findings, the American College of Radiology gives radiologists guidelines on how to manage them. And this guidance is then passed on to the primary care providers so that we're not chasing after things that don't have any clinical benefit. Next slide. Some radiology groups today are using computer-aided detection to help them find and measure lung nodules. It's a useful tool to help reduce false negative results and to measure changes in nodule size over time. This is something that works alongside the radiologist. Each nodule finding is verified by the radiologist. Next slide. And on the horizon are revolutionary artificial intelligence systems that can see and detect things that we can't with the human eye. These AI algorithms are still difficult to create today, and there are challenges to validating them because the data that you use to train the system has to be so carefully curated. But efforts on this front will have great benefits for lung cancer screening in many ways. For example, it can take in and process clinical data about each patient to create a personalized risk assessment and optimize who is eligible for screening rather than using the sweeping generalizations that we use today. It can help us with image acquisition by adjusting the CT technique for each patient in a way that maintains image quality but reduces radiation exposure even more than we've done today. There will be AI-based systems for automated nodule detection to reduce the manual workload that we have today and eliminating false negatives. And most importantly, it will provide characterization of nodules as benign or malignant so that unnecessary biopsies or surgeries are avoided. Next slide. Now, differentiating benign from malignant nodules on CT with an AI system has the potential to help us decrease the number of unnecessary follow-up scans and biopsies on patients with nodules that are low risk. There's one model today, for example, that reduces the false positive rate on a baseline screening exam from 14% with a human reader down to 8%, while still maintaining a high level of sensitivity for lung cancer. So AI may be, and in some cases already is, more accurate than a radiologist. And that is why pursuing this technology as it applies to medical imaging is worthwhile. So that's our look into the future. Thank you for your interest in lung cancer screening. I hope you've gained some useful information to make you an even more successful partner in lung cancer screening. So please remember, check in with your patients and help keep them on track with recommended follow-up exams.
Thank you, Dr. Brandman. Dr. Nanin has the last word, and I'm sorry for the feedback you're hearing. Dr. Matthew Nainen is a general thoracic surgeon. Sorry, Nainen, I'm going to do an intro first. and Director of Thoracic Surgery at HCA Florida Healthcare West. He's a founding board member and current president of the Florida Lung Health Coalition. Please go ahead, Dr. Nyland.
Thank you so much. After those two wonderful discussions from Dr. Shulkin and Dr. Brandman, it's going to be difficult to measure up. But let me just try and talk to you something about what happens once these patients have been found to have lung nodules. What are the modern techniques we have to make this pathway as smooth as possible? And also a few words about veterans. So when we look at veterans, we've seen that they have a large incidence of lung cancer, and it is challenging. It is a very challenging patient group to see what is going on. Now, in 2007, 2008, I think, or maybe even a little bit earlier, maybe 2006, I was sent a patient from Fort Campbell, Kentucky, which is very close to Nashville, Tennessee, where I practiced at Vanderbilt University. And this gentleman had, he said, "Doc, I used to run 5 miles a day. Now I can hardly run a mile." But when we look at his pulmonary function testing, he was still scoring in the very high percentage of predicted range because he was already functioning so much above the standard patient. And he had returned from Mosul in Iraq. And then as I got to take his history, I found that he had been exposed to various smoke-related burn pits and other things, and sulfur from sulfur mines also. There was a lot of smoke in the Mosul area post-invasion of Iraq at that time. And so I talked with his pulmonologist, and he became the first patient that we actually biopsied for this condition back at that time. And this resulted finally in an article that was published in 2011 in the New England Journal of Medicine, which the whole team was led by Dr. Robert Miller, a pulmonologist at Vanderbilt. And we had to work through with pathology as to what the features were, etc. And we found constrictive bronchiolitis to be the major event in these patients returning after exposure like that. Next slide, please. So we had 49 soldiers. Most of them were non-smokers. Prolonged exposure to sulfur dioxide from a mine fire, open burn pits, severe desert storms, etc., could contribute to this condition. And the results showed us how environmental factors can greatly influence lung health. And I think what is happening in the general population is we are undercounting the amount of environmental exposure that we have. And the smoking becomes a huge additional factor in these patients. So this led to people like Dr. Shulkin and John Stewart and many others taking this on within the VA system and making it a something of national importance that helped us to come to the law in 2022 that has helped these patients and will continue to help them. Next slide, please. So this led to this whole field of deployment-related respiratory diseases. Next slide. And, it can occur anywhere from your nasal cavity all the way down to your alveoli. So there are multiple changes that can occur. And a lot of this have been found in veterans from various deployments abroad. So this is not just in the lung. It can occur in the airways. It can occur in your upper nasal passages as well as the upper airway passages. Next slide, please. So I'll just skip through this quickly, but I just want to use this to say that veterans have been identified with lung cancer for a long time. This was a study that looked at those that were identified in the system between 2010 and 2017. As you can see, overall survival is gradually getting better for these patients. In stage 1, it went from 58 to 68.4%. In stage 2, it went up again to about 50%. And also, even in stage 3 and even in the later stage 4s, we are able to show some improvement in these patients. And this is very encouraging news. That means that finding these patients is no longer a death sentence, is no longer something that we should ignore for weeks on end, because we have a lot of data that tells us that time to treatment is very critical in these patients. So our motto in the Florida Lung Health Coalition and Lung Health Coalition in general is to find them early and pass them on. That is essentially, in short, what we are here for. Next slide, please. So let's just quickly look at what some of the cutting edge technologies that are in practice today that are helping these patients. One is that AI in screening in the community is an extremely important tool. People who have deployed it countrywide, like in the United Kingdom and other parts of Europe, will tell you that without an AI-powered system, we are finding it difficult to keep up with the number of patients that are requiring first images, follow-up images, and how are we going to tackle this? So we have ways of enhancing patient encouragement and patient engagement, and to encourage them to undertake LDCT. There are outreach models out there that are allowing us to reach the correct population and allowing us to take that population and encourage them to attend LDCTs. So this can result in a pickup that is much more than standard ways of approaching these patients. So the pickup technology that we commonly use in practice today is natural language processing. And that is something that reads the radiology report, essentially picks out keywords and tells us that this is the way that we pick up both in the incidental and the screening population. We have one in our company, which is called Patient ID. And this has helped us over the years detect multiple patients with missed and overlooked lung nodules and other lung pathology. The disadvantages of this is that you can miss nodules. We can, pick up terminology is not the same all over, that radiologists often use their own terms, and this can be a problem. So thus a technology that can actually read the CT scan for you can be quite beneficial. Next slide, please. So that's how we started working with Radnet as well as their company Aidence in the Netherlands. And we started to integrate these systems into our PAC systems to tell us that we could discover lung nodules, etc. And I must say that they have been extremely successful in integrating this on a countrywide basis in the United Kingdom. And we have a lot to learn from those societies as to how we can do that in our own society. Next slide, please. So one of the areas that has been growing rapidly is to look at liquid biopsies. And by liquid biopsies, we mean that we take the peripheral blood and we test for enzymes, for molecular basis of cancer that we can find in the blood. Now, if you look at that, there are multiple mutations and fusions that are actionable that can be present in early stage lung cancers. So today we are even using liquid biopsies to show us what is the type of tumor, what are the actionable mutations, and how can we treat these patients better. So if you look at the left side of the screen, you see that in early stage lung cancers, there are multiple mutations and fusions that we can pick up both within the tumor, but not just within the tumor, but within the blood also. Next slide, please. So when we look at liquid biopsy in the lung cancer field, you have multiple companies in this field. It can get very confusing for people, etc. One is that for screening purposes, we have the multi-cancer screening tools that you must have read in the newspapers. You do a blood test and you can detect 50 cancers and things like that, which is true to some extent. However, the false positive rate is very high in these. So it can, we really don't know what the true value of this is going to be. It can lead to a lot of investigations that are not necessary for the patient. We don't want to send them down a path that the treatment is actually, sorry, the investigations are actually worse than the disease itself. There is also specific lung cancer screening, and this has been, various methodologies have been proposed here. These are much better because the false positive rates are lower and the false negative rates are extremely low. And that is absolutely critical for us, because then we can do a blood test and we can tell them, listen, if you have a blood test and it is negative, then you may not need an LDCT right now. We can safely wait to the next year for you to have another test and then tell you when we should have an LDCT. So essentially, some of these tests can act as triage tests. And this is something that is worthwhile investigating, because we proposed in the Lung Health Coalition that we could actually increase the number of LDs, total number of LDCTs. You have seen from previous slides from the other speakers that the rates of screening are so low. So if you can actually screen increase the screening numbers big time, then what you will find is that the total number of LDCTs that we are doing could actually be better if we are able to find other modalities to triage screening. And we are working on this through the Florida Lung Health Coalition in Pasco County in Florida. We can test for mutations for therapy. We can do all those other things in that previous slide. One of the ways that we can also use ctDNA and ctRNA to tell us as to how the patient is responding to therapy. That is the circulating tumor DNA and circulating tumor RNA. So these are all very, very exciting fields in the lung nodule continuum. And there is a lot more to come in this field. Next slide, please. So if you look at one of the ways in which we can screen these patients that have possible high risk for lung cancer, which are the USPSTF criteria that we have seen in these previous slides, you can find that the patients that are having lung cancer release not only full sequences of DNA in the blood, but they also release cell-free DNA fragmentomes, which are tiny bits of genetic material that are circulating in the blood. If we can actually pick them up and say that these fragments are those that are coming from tumors within the lung, then we have an effective screening tool. The other big advantage of using this is that we do not have to use next generation sequencing, which is expensive, which is about $2,500 minimum per test. But with these technologies, we are able to bring the cost down to between $100 and $200 per test. So it really starts to have an effect in the early stage screening process. So the idea would be, in the traditional route, which is on top of the screen, individuals at a high risk have an LDCT. But these patients usually have an annual non-invasive screening using blood tests, meaning when you go to your PCP and have your annual visit, or you can actually draw blood at a large, let us say, an American Legion function, for example. So you can then say that patients who are negative or have a low risk for the test can go to annual screening, but those that have an elevated risk go in for an LDCT scan. Next slide, please. And we know that early stage lung cancers can be detected using circulating DNA, but nowadays close to 50% of stage 1 lung cancers have got circulating DNA that can be detected. As you go to stage 4, look at it, 83% of patients have circulating tumor DNA. So this is going to be something that there's a lot of work going on, and we will be able to detect cancers better and better through blood tests. Next slide, please. Again, just to show you that patients who have circulating tumor DNA actually do much worse than those that do not. So it is also prognostic. So if you have an aggressive cancer, it could be that you're putting out ctDNA. Or if you have like one of those that Dr. Brandman showed you, that could be a slow growing or a in situ cancer, they are highly unlikely to have ctDNA circulating in the blood. So maybe as these technologies develop, we will be able to additionally, rather than just radiology, tell the patient, okay, you have a low risk and you can probably wait and have a screening next year. But these are the patients that have a high risk, and you need to go in for biopsy and possible treatment. Next slide, please. You can skip this. You can go to the next slide. This is some of our data. We have now in our system, in my hospital, we have close to 400 blood draws in patients who have had some form of therapy for lung cancer. This is all early stage patients. Those that were what we call shedders, that is shedding ctDNA into their blood, about 71% of them we found have some form of actionable mutations that we can give to our medical oncologists and say, maybe these are the patients that you need to treat further and maybe after surgery, and maybe these are not. And if you're non-shedders, it is very unlikely, at least there is a 2/3 chance that you do not have lymph nodal disease. Next slide, please. We just look quickly at the field of procedural advancements. There's a huge amount of work going on here. The first and foremost, we have to take out less lung when we operate on these patients. One of those, we are working with this excellent company from the Netherlands again, that we call these deformable models. I keep them next to my robot and I use them because it gives me an exact anatomic representation of the patient just based on the patient's CT scan. So based on the CT scan, it recreates this 3-dimensional image for me, which I can also look through it through the robotic console. And it tells me that yellow is where the tumor is. It tells me where the blood vessels are. It tells me how I can see the bronchial anatomy, and thus I can do a better operation on these patients. I can plan my operations. So this is what is necessary so that we are able to do less and less for these patients. Right now, our Society of Thoracic Surgeons data for our institution shows that of all lung resections, those that are 90 years old to those that are 50 years old, we have a 48-hour stay after robotic surgical planned resections like these. And that is an amazing place to be. We need to get it down even further. I see a day in the future where it might be an outpatient procedure. So this is what we are slowly working our way towards. Next slide, please. So one of the major issues that we are working on is to reduce time to treatment. Time from diagnosis matters. The time from diagnosis to treatment matters. When you find them in the community, you find patients are wandering around for 2 months, 3 months, sometimes visiting various specialists, doing all these tests, etc., etc. And this does not bode well for patients. This is an older study from a Canadian center that says that the long-term survival, that is 5-year survival, is significantly impacted the longer the patients waited after diagnosis to have therapy. Next slide, please. So what we have is that we have these combined rooms where, to your left is the robotic console, and you can see the robot right there in front of you, the surgical robot. And as we turn, we have the bronchoscopic robot all set up in the same room, so that we provide diagnosis and treatment at the same sitting under one anesthesia for these patients. So when these patients are referred to us, we can do both of them together. So we do a combined event, and we have done close to 300 of these now in the hospital where I work. And this has reduced the time to treatment. We have the lowest in our system. Our time to treatment is down to 13 days now from the time the patient first as a mean, from the time the patient first presents to us to the time they get their definitive therapy. Next slide, please. This is just, we use augmented fluoroscopy that gives us almost CT type images. That may not be enough for accurate diagnosis, but is great for us to find these nodules and biopsy them, so we can use these in the operating room. Next slide, please. we can mark these tumors. Can you just go to the next video? So that is a small cancer in the lower lobe with the robot, and we have marked this using the robotic navigation systems. And through this, we are able to say exactly, we use ICG, and you can see how well it marks that tumor. It tells us where it is, and thus we can decide what kind of a resection we need to do. How can we save the more lung on this patient, etc. Next slide, please. Our combined, this was some of our earlier data. We have now doubled the number of patients. We have made sure that these patients are chosen appropriately. 96% of these patients have proceeded to surgery, so we do not need to cancel. The mean in-room time for this was very much an acceptable time. Next slide, please. We have proposed indications in which we can combine these treatments so that it is both patient-friendly as well as provider-friendly. Next slide, please. So I just want to end by talking about the Florida Lung Health Coalition. Our aim is very ambitious, and I request everybody to join us. We are not healthcare system centric. We are open to anybody. We are here to help people achieve a screening rate of 30% by 2030. And this is a very ambitious goal, but we are working on it. And I must say, since just 1 year of our founding, there have been many, many people who have given their time to help us get there. Next slide, please. Our priorities are we want to increase access to adults at risk, especially those that cannot afford it, or patients from minority populations that have a worse outcome. We are direct at-risk patient outreach with different methodologies. We realize that this is a community effort. This is not going to come from some ivory tower. So the PCP involvement is absolutely critical. They are our friends in this outreach, and they are our main focus from the physician community. State-of-the-art technology, patient navigation, fundraising to remove economic barriers, and finally, data collection. Next slide, please. So we have two pilot initiatives. One is a screening with blood test initiative in Pasco County. Our aim is to do this within a specifically defined geographic area. Pasco County, Florida has 500,000 residents, and so we know how many patients are at risk within that defined population. If our aim is to get the data from a single geographic region and show the powers that be in Florida, our leaders, that this is worthwhile doing in a single county in Florida. Thus, maybe they can expand it Florida-wide. The second is a pilot that is doing the same thing, but we are doing it to remove financial barriers in the east coast of Florida, which is the Treasure Coast. But there we have a traditional approach of removing financial barriers and reaching those disadvantaged populations to get them to do further LDCT related screening. And we have launched targeted outreach. We are working with primary care physicians. This is one of those sessions that we are reaching out to more physicians. We are trying to remove barriers to screening, which include fundraising, providing PCP orders, improving this whole shared decision-making business. How do we overcome the problems with that? Next slide, please. Thank you. Any questions? We are happy to entertain.
Thank you, Dr. Nainen. If the speakers can turn on their cameras, then I'm going to look through questions. We don't have much time for questions, I realize, but here is one. Underutilization of lung screening is a problem, not only in Florida, but nationwide. Why do you think that is? Dr. Shulkin, do you want to take that one?
Sure. Look, I think it's probably for a number of reasons. preventive services have always been challenging. It took us many, many years to get mammography rates up, to get screening up for many preventable illnesses. And it took a lot of years of education at both the provider level and the public level. The insurance companies with lung screening were much slower to adopt payment, but now all of them are there, including the government agencies. And so there aren't as many barriers. So this is primarily about educating our patients, getting them in the door. Access to screening now with initiatives like the Florida Lung Coalition is making it much easier. But this has been stubbornly slow. And I think that unfortunately, we're seeing a significant number of malpractice cases now against physicians who have failed to do screening in high-risk individuals who then go on and develop cancer. So I think that it really is important, and I'm so glad to see people joining this conference call to be able to know that this is something they should be providing their patients.
Thank you, Dr. Shulkin. I see here one question. I think this is for you, Dr. Brandman. How do I find the patients in my practice who are eligible for screening?
Thank you for that great question. And I think the answer probably really depends on the size of your practice. If you're a smaller practice, then perhaps the provider in the room with the patient performing the eligibility and shared decision-making at the time of obtaining the patient's social history might work for you. Whereas if you're a medium-sized practice, perhaps you can have a questionnaire in the waiting room that patients fill out to identify patients who are eligible, and perhaps you have a staff member who can help flag those patients for the provider, so the provider knows to complete the shared decision-making with the patient. If you're a member of a larger practice, what we've seen is the most useful is to have it built into your EMR and to have electronic prompts for the providers when they're in a patient's chart, indicating that the patient's social history qualifies them for screening and requiring the provider to respond to that prompt. We've seen that that really goes a long way for providers to find those patients who are eligible. And just always keep in mind that this time is something you can bill for under G0296 and earn credit for the time that you're taking to find those patients.
Thank you, Dr. Brandman. Let me see. We hear about innovations all the time in healthcare. What's the latest in lung screening? Dr. Nainen, I remember you speaking about that. Anything new that you didn't address in your presentation?
I think most of it was addressed in my presentation. I would say better radiologic techniques like radiomics that gives us a lot more information about that nodule. Better AI use within radiology, better use of blood-based testing. These are all, I would say, the technology improvements if we can actually get the patients to step up and get screened. So for that problem, we really have to have better systems of identifying populations within a defined geographic area that are at high risk and where we will get most quote-unquote bang for our buck in terms of getting screening and working towards that. So there are a lot of models of that type that are coming out today with a lot of population-based type systems. Those who attended our Florida Lung Health Coalition kickoff saw the presentation by Dr. Levy from Detroit. He has used Google technologies to identify these patients, etc. So there is a lot of work going on that side. So one is the identification and targeting. And the second is, once we target them, do we have better ways? Because we found that LDCT is somewhat difficult to get patients through the system.
Thank you, Dr. Nainen. I'm going to stop the Q&A here. So thank you again, gentlemen, for your insights. We hope this session has been useful for our participants, and especially that it has an impact for patients who can benefit from screening. I also want to thank you, all of our attendees. If you have questions, please don't hesitate to contact the Florida Lung Health Coalition at any time at info@floridalunghealth, all one word, .org. That's info@floridalunghealth.org. We also will be emailing you instructions for how to obtain your CME credits today. Thank you.